Without delay, I'll go into the topic. So the topic allotted for me is paraneoplastic retinopathy. Can I have my slides up, please? Yeah, so paraneoplastic retinopathy is a subgroup of an umbrella term called autoimmune retinopathy, which is a rare autoimmune degenerative retinal disorder caused by cross-reactivity of serum antibodies against the retinal antigens. Now, paraneoplastic retinopathy, as the name suggests, is associated with cancers, and there are four distinct entities now: the carcinoma-associated retinopathy, melanoma-associated, paraneoplastic vitelliform maculopathy, and bilateral diffuse uveal melanocytic proliferation, or BDUMP. So if a patient comes with symptoms of shimmering or flickering of lights, with scotoma and transient decrease in vision, with a apparently normal looking fundus, what do? We usually tend to send the patient, reassure the patient, and send the patient back home. But if we have something non-specific fundus findings, we tend to look deeper. But what are we exactly looking at? So very important to know that these very vague symptoms can be associated with carcinoma-associated retinopathy. So because it's an autoimmune disorder against the photoreceptors, it can have non-specific symptoms associated with either rod dysfunction or cone dysfunction, so photosensitivity, glare, nyctalopia, etc. Important thing to note is the fundus can be absolutely normal or can have features like arteriolar attenuation, mottled RP, and disc pallor, which looks like retinitis pigmentosa, or can have something looking like uveitis, like mild vitreous cells, sheathing, periphlebitis, etc. So ERG is going to be again like retinitis pigmentosa, diminished photopic and scotopic responses with field changes. Now, like I said, it's autoantibodies against the tumor antigen that cross-react with the retinal proteins and result in the dysfunction. So multiple autoantibodies have been implicated. The most common is recovering and alpha enolase, and only in 65% patients we actually have a detectable autoantibody. Okay, so to bring it to everybody's notice that these autoantibody testing are done in very few centers across the world and are very expensive, and it's very difficult also to send the sample from here to another country because it has a lot of paperwork involved in it. So the take-home point for carcinoma-associated retinopathy is, if a patient comes with recent onset of photosensitivity, ring scotoma, and has arteriolar attenuation or any of these features, look in for an underlying pathology, because visual symptoms precede the diagnosis of malignancy in up to 50% patients, and the associated malignancies can be small cell carcinoma or any of the gynecological. Okay, so coming to the next part, that is, so a 66-year-old gentleman came with recent onset of night vision difficulty, both eye cataract surgery done. Best corrected visual acuity in both eyes was 6.9 with few drusen. I don't have the fundus picture, unfortunately. So I did not know why this patient was suddenly complaining of night vision difficulty. But then her son came in and gave the history that her father was diagnosed with skin cancer 4 years back. And there I had a diagnosis of probably looking at melanoma-associated retinopathy. Here again, the fundus can be completely normal or can have, again, very vague, non-specific findings like white atrophic patches, diffuse RP, atrophy, blunted foveal reflex, and visual fields are also going to show some changes. Now, in most of these cases, there is already an underlying diagnosis of a cutaneous malignancy, and that makes the job easier for us. If it's not diagnosed, we need to suspect and send for the appropriate workup. So pathogenesis here is the presence of an anti-rod bipolar cell antibody that is against the TRPM1 receptor. There are other associated antibodies as well, like transducin, aldolase, C, aldolase A, mitophilin, etc. What is interesting about this TRPM1 is that this TRPM is actually the mutation of TRPM1 receptor causes congenital stationary night blindness. So what do we expect in ERG? On bipolar cell dysfunction is going to cause an electronegative ERG, but in these cases, the night vision difficulty and the electronegativity of the ERG will be subacute in onset in an adult. Okay. So the third entity I'm going to talk about is the paraneoplastic vitelliform maculopathy. So they are these vitelliform lesions over the posterior pole at the level of RP associated with serous macular detachment. They closely resemble polymorphous vitelliform maculopathy and Best dystrophy, and are associated with both choroidal and cutaneous melanomas. Now, earlier these were classified under the melanoma-associated retinopathy, but increasingly there are reports of cases to be associated with carcinomas as well, and that's why now we have this in a different entity altogether. So the rarest of the entity is BDUMP. So as the name says, it's bilateral. It has diffuse melanocytic proliferation, and it often precedes the diagnosis of malignancy. And we don't know how it actually happens, but there is the role of a culture melanocyte elongation and proliferation factor in this. So this is a late presentation, 6 to 9 decade of life with rapid onset of painless bilateral decrease in vision. Now, Dr. Donald Gass has given these cardinal signs. So they are these multiple subtle round red patches, and on autofluorescence they will be hypoautofluorescence, but on FFA they will be hyperautofluorescence because of the RPE loss, and there'll be diffuse thickening of choroid and with focally elevated pigmented tumors. They can be associated with exudative RD and rapidly progresses to cataract formation. Now, very easy to miss them when the pigmented tumors have not developed, because we think we are looking at a uveitic entity, and after the the pigments have appeared, we still can have many DDs. But what is important to remember that they are bilateral and they involve the entire uveal tract. So the survival of these patients is actually quite less, and plasma exchange has been suggested as a treatment. So now this is the most important slide of the presentation. If you have an adult with rapidly progressive bilateral unexplained vision loss, normal looking fundus or unexplained findings, and if your ERG also shows rod and cone dysfunction, plus minus if you can get autoantibodies done, so you're looking at paraneoplastic retinopathy, and it warrants the systemic survey for malignancy. Thank you.